Dear colleagues, I am Dr. Narendran. I work as scientist E medical in the Department of Clinical Research in National Institute of Research in Tuberculosis. I am going to concentrate on management of patients with HIV TB co-infection, talking about the catastrophic comradeship between the two diseases. Going by the statistics, thanks to the program, now measures have been taken that HIV epidemic is a declining epidemic as of now, but still because of the rampant progression of TB, we still have importance to this dual diseases. It is a perfect syndemic, I tell you, because the reason is that if you take HIV reduces immunity of the patient. As the CD4 goes down, you have TB creeping in fact in all stages of HIV. If the CD4 is quite high, you have typical TB with typical manifestations. If you have CD4s between 200 to 400 or 100 to 200, you have typical TB with atypical manifestations. As you touch the abyss, you have CD4 less than 100, you have all other non-tuberculous mycobacteria with both typical and atypical manifestations. If you look at what TB does to HIV, because of the inflammatory cytokines which are released into the blood, they act like proactive growth factors, increasing viral replication. The statistics are here for you to read. HIV complicates every aspect of TB, starting from diagnosis up till management. Hence, starting with the diagnostic issues, even though pulmonary TB is the commonest TB in HIV also, surprisingly you will see that there are more extrapulmonary forms as well as isolated extrapulmonary forms which are much more frequent than in patients without HIV infection. 4% of them asymptomatic HIV we have been able to isolate culture positive for tuberculosis from the paper by Dr. Swaminathan. Normal X-rays do not rule out TB. If you look at the X-ray in a HIV patient, as the CD4 goes down, if the CD4 is below 100, the typical CD4 alveolitis which is required for you to produce an inflammation and insight and opacity in the X-ray is not actually there. That is the reason in fact that X-rays may be normal. Smear negative TB could be due to a wide spectrum of other opportunistic infections which could infect the patient with HIV. Hence, we are close to getting a good diagnostic algorithm, but still there is a long way to go. The CBNAT has been a limelight test and has been helpful in various ways which has been now advocated in the program for HIV patients. One, you are able to diagnose very little amount of TB infection, so you are able to start treatment very early. Two, you are able to diagnose MDR TB at a very early stage and try to start the patients or change the management treatment in these patients. More importantly, if there is an immune reconstructive inflammatory syndrome, CBNAT will help you to differentiate resistance from iris. Coming to chest X-rays, you have wide spectrum of presentations. They can range from absolutely normal chest X-ray to complete whiteout of the lungs as in miliary. If you look at the chest X-ray in the left, you see it is almost normal, but all that you see, which I would like you to appreciate, is the fundus shadow almost overlapping the splenic flexure shadow, which shows that beneath the stomach bed where the spleen shadow is supposed to be there, it is absent, which is actually a surrogate marker of immunodeficiency. If you look on the right, you have typical miliary pattern almost involving the entire lung. Most often you see multitude of lesions where you have mediastinal adenopathy, consolidation, pleural effusion. Pleural effusion usually are bilateral, but they are absolutely asymmetric. You will never have symmetric effusions in HIV. Looking at the cavities, well delineated, well demarcated cavities are conspicuous by their absence. All that you see is small areas of consolidation coalescing to form cavities. Treatment of TB in HIV. If you look at the anti-tuberculosis treatment, it is more or less similar to what is being given in HIV negative patients. Based on the trials, we have evidence that a 6 months regimen of anti-tuberculosis therapy, even if intermittent, has got as equivalent results as a 9 months ATT, but we had bacteriological recurrence more because the study was done in the pre-HAART era. Ours is the only global evidence to say that daily regimen has a better efficacy than intermittent ATT, especially in HIV with pulmonary tuberculosis. But there was a small price to pay in the form of increased hepatotoxicity. More importantly, if you look at the risks and benefits, daily regimen has got the advantage of preventing emergence of drug resistance, which is very important in HIV. Non-rifampicin regimens are quite inferior. They require longer duration of action and more cumbersome, and has led to lot of non-adherence and defaults during drug intake. For patients on protease inhibitors, because they either do not tolerate NNRTIs or they have failed therapy, rifabutin is an ideal choice. It has been to be given 300 milligram thrice weekly or can be given 150 milligram daily. It is very good to substitute for rifampicin because it has interactions with protease inhibitors. Internationally, people have even started giving rifabutin 300 milligram daily. Looking at the newer drugs, bedaquiline and delamanid, they also need to be adjusted when ART is given. Efavirenz reduces bedaquiline levels, whereas protease inhibitors increases bedaquiline levels, hence they need to be very closely titrated. If you look at ART, what regimens to give in patients with TB, the preferred choice is tenofovir disopropyl along with lamivudine and efavirenz. Of course, lamivudine can be substituted with emcitracibine. The advantage is you have an FDC, it is a single pill, the pill burden is reduced. There are lots of drugs which are getting phased out recently. Stavudine has already been phased out, nevirapine and zidovudine because of their side effects. The recent trials have proved that among second line and reserve drugs, there are certain drugs which could not be given with rifampicin. The CCR5 inhibitor maraviroc, rilviprin, the integrase inhibitors elvitagravir, more importantly tenofovir afalanamide. Even though there is definite advantage of using TAF instead of tenofovir, because 1/10 of the dose is more than enough and there is huge reduction or a drastic reduction in renal toxicity as well as bone marrow density reduction. Now all these side effects are actually taken care of by TAF, but unfortunately when you are giving it along with rifampicin, it is not possible because TAF doses are reduced to subtherapeutic levels. We have already clearly ruled out in various trials that double boosted PAs or double dosing of PAs cannot overcome the problem of rifampicin interaction. Recently, double dosing of integrase inhibitors, both dolutegravir as well as raltegravir, can be safely given with rifampicin, but the trials are still going on for effective conclusion. How do we know that the patient has responded or not? This is an important slide for practicing clinicians in HIV and TB care. There are situations in which the patient may respond, but you may take it that the patient is not responding because of the symptoms and signs that are being presented to you, or it could be that patient is really deteriorating. How do you find out? Now this list is not all inclusive, but the main reasons which need to be evaluated are listed here. You know the TB related is very easy, patient is not taking antituberculous treatment mostly because of alcoholism and drug abuse, or he has developed resistance to TB. But if you look at the non-TB related causes, they are much more important, much more frequent for you to see because they are usually not present or not overtly presented by the patient. The most important is biological failure. If the patient is failing ART because he is being taking the drugs for a month, he has been supplied drugs for a month, if you do not ensure adherence, if there is non-adherence, if his virological suppression is not perfect, then again there is resurgence of viremia which can lead to a CD4 breakdown and that can lead to TB recurrence or failure. More importantly is the CD4 level. If in patients with immunological discount where the CD4 does not come up, even though there is effective virological suppression, still you could see that the patient is not responding. He cannot clear the TB bacilli or any opportunistic infection unless the immunity comes up. The other is cryptic non-adherence due to malabsorption. If the levels are low, he is not able to absorb due to various reasons including HIV enteropathy, diarrhea with decreased gastric transit time. There could be lots of reasons, but if the levels are low, then the tissue levels are much more low, that leads to failure. Coming back to apparent non-responders where the TB has responded, most important is immune reconstruction inflammatory syndrome, where because of the inflammation created by the restitution of immunity, you think that the patient has developed symptoms and signs, but actually he is doing well. The next is non-tuberculous mycobacteria. As I told you, if the CD4 is quite low, you can have non-tuberculous mycobacteria where the smear will be positive but cannot be caught on the regular conventional cultures we do for M tuberculosis. We need special stains and reagents to prove it is non-tuberculous mycobacteria. In such situations, you may think that the patient is not responding. The other mimics are PCP and nocardiosis, especially if there is a pleuropulmonary involvement. Bacillary escape is a very unique situation which we find where you have minimal colonies which are totally resistant. You do not have to panic. The classical thing is that the patient is asymptomatic usually. The cultures and smears have already converted, and suddenly you see a culture less than a grade with a few colonies throwing up in the sputum examination, which is totally resistant. That is what we call as bacillary escape, which can occur in non-HIV also. I finished the end of my first session. In the second session, I will be trying to get into the interaction or the influence of each of the diseases and what it creates, how it creates problems to the physicians during management. Thank you.